Thank you, Professor Omkar, as well as the participants of this instruction course. At the very beginning, I like to say one or two lines. If we like to do any sort of work, any sort of service, the first requirement is need assessment. Is it necessary to do this work? Then the magnitude of necessity, how much is necessary? After having this need assessment, we can proceed to find out the ways how we can do this need assessment. And after getting some baseline data from our needs assessment study, which is being done by screening procedure, we can plan how to implement our services to the community in need. That is the very basic words of community ophthalmology, what I am practicing for the last 44 years. And as a part of the Association of Community Ophthalmologists of India, as a student of community ophthalmology from the International Center for Eye Health, London, as well as a government ophthalmologist serving at the mobile eye unit attached with Bankura Medical College for long 17 years as its senior surgeon, and afterwards as a faculty member of so many medical colleges in West Bengal as well as in Chhattisgarh. This is my core idea that need assessment is the premium part of any service, and need assessment always requires a beautiful screening procedure. To start with my deliberation as an introduction of this beautiful smart technique for ophthalmic diseases in the community, I just like to tell you some interesting part of my life. Long back, about 40 years back in the year 1984, what I experienced as a young ophthalmologist like Professor Omkar, when I was posted as senior ophthalmic surgeon and in charge of mobile eye unit of Bankura Medical College, which was meant for the 7 southern districts of West Bengal. Once I got the message and direction from Government of India to go to a district in Purulia to go on with a door-to-door survey of one community in search of eye diseases. In those days, what I will say in my presentation, that what was the traditional method and what change we like to make it through smart technology, it was nothing but door-to-door visit and recording of the eye diseases. So we got the message from Government of India that you will have to go to a village known as Begun Kodar in Purulia's district, which is at the border of Jhalda and Purulia, that is of Jharkhand and Bengal. Begun Kodar district you will have to go and have to screen those patients. This sort of selection of villages and this instruction from Government of India were being given a computer analysis and computer detection method. The computer has selected these villages all over India, and those are the ideal villages where we should go on for door-to-door survey and should take this data and others. But now the whole system is changed by the smart technique and others. What the recent RAB survey done by Professor Praveen Vasisht has done, this is totally different because of the beautiful experience what I got. On reaching the headquarters of Purulia district, when we asked the chief medical officer, sir, we like to go to Begun Kodar village for survey. We are coming from Bankura Medical College. So they are going on, yes, Begun Kodar, yes, it's near the Jhalda border like this and near. So you please go to Jhalda and try to find out the village Begun Kodar. So we went to Jhalda. Then reaching Jhalda, the sub-divisional health officer told, oh sir, that village is already devastated by flood. No person is there, no villager is there. You just see, going from Bankura to that Begunkodar 300 kilometers with my big team. In return, there is no villager, no presence of that particular village. So that was the fun. But there, all those has wiped out. And so we have come with this particular session. What we like to have this, that why screen differently in for ophthalmic disease in the community. I have got no financial disclosure in this presentation. So community ophthalmic screening methodology, what I have told, that is a part of the need assessment study towards a service-oriented formula to do something towards our national program for control of blindness. So it includes documentation, active patient participation, accurate clinical data management, and referral in tribal setting, and leveraging technology and portable devices. You always know, and you should always remember, that screening without service is of no good. Going to a village, find out 2 or 3 cataract patients, you are documenting. The second question of that particular blind person, sir, you have documented, I have got cataract, it requires surgery. So what next? Where should I go? How can I get the treatment? If you say, I do not know, then they will not allow you to go into the other doors. That's why you should be always ready with the service part also, and you have to direct that particular person what would be the next service to them. And that's why this particular technique, what we like to present before you, and what design of this instruction course has been done by Professor Onkar, is known as SMART. Very correctly, it's a social engaging. We have to include all the parts of the society in this. In this context, I like to tell about a beautiful part of our community eye health practice. In the year 1995, we have made one beautiful Raniband model in Bankura, what has been published in those days in the weekly bulletin of the School of Tropical Medicine, Liverpool, London. In that, we engaged some villagers only up to the education of class 8, and they have been trained in the nearby Bharat Sevashram Sangh, and where they have been asked to go door to identify the blinds and to motivate them to the nearby health center for some services. And that is social engaging. Second, it should be manageable. Money, manpower, and mentality is the part of the community of ophthalmology. So every part of our practice should be manageable with these 3 sources. We must have got enough resources, enough manpower, as well as mentality of the people. It should be achievable. It should be practical. It should be reliable, and over and above, in this 3rd decade of 21st century, it should be technically enabled. Now, we just like to give a bird's eye view what was there and what should be there. The traditional eye screening method, and what through the smart technology, what we like to do. In smart traditional method, we usually made manual door-to-door visit with manual documentation, direct examination of the eyes, and as well as visual acuity test, eye pressure, and physical examination. You'll be surprised to know, with a piece of rope we used to send our community eye health workers, maybe a village volunteer or some ASA worker, to each and every door to door, and they asked all the family members to come on the courtyard, and we asked them to count the fingers at a distance of 3 meters. In that way, very crudely we like to find out how many of them are visually handicapped, so far as without any spectacle examination or operation or anything like that. So those people have been taken to a nearby screening center where we like to have the spec test and others. But nowadays, it's all digitalized. It's all digitalized collection of this, our information storing and manageable health structure. It should be accessible. We should go not to door like all those days of traditional by person to person, but it is all based by our digital methods, and it is flexible, accessible, and allowing for remote monitoring and use of telemedicine technologies. And the data management. In those days, it was all manual. We're coming up to our base camp, and every night we like to go on with all these permutation, combination and compilation. But nowadays, those days have gone with the plain and paper, but it is all digitalized with data management and real-time updates and data analysis. Efficiency. In those days, these volunteers with 3-4 days orientation, or the health workers with 7 days orientation has been sent to the field for door-to-door visit and others. But nowadays, it is all technically oriented, and it is all being oriented by our automation, remote monitoring and data-driven decision. But above all, cost. This door-to-door data collection was very much cost-effective, very much expensive, and it was not feasible in those days. But nowadays, with this initial setup cost, the startup is a bit costly, but afterwards it is very much manageable. That can give rise to a cost saving and improve resource allocation. And above all, it gives a preventive care. But only one thing, this machine can give everything without very personal communication, with very personal attachment and very personal cure or resuscitation and relief and reassurance, what this particular traditional system can give by this way. And above all this can be done with integrating with our healthcare system, where there will be a personal touch as well as a digitalized method of screening system. And that can only give rise to a more holistic approach to patient's care. Thank you very much. And we are sure that this instruction course will be very much acceptable to all of you, and you will also try at your own place with this particular method, smart method. Thank you very much.